So this session is around the future of Scan4Safety. We've had some great examples over the last 2 days around Scan4Safety in action across multiple use cases. What we want to talk about today is, what does safer, smarter, connected healthcare look like? So let's give Nata a break for a minute. Steve, would you like to start?
Thanks very much, George, and good afternoon, everybody. Just as to demonstrate my N+1 resilience, I have brought it electronically because this is my notes electronically because this is a digital type forum, but I've also got my business continuity plan just in case of failure. The experience for Leeds, and just sort of talking about where we are and where we're going, we were part of the first phase of the Scan4Safety program in 2016, and very rapidly included our acute trust collaborative, provider collaborative called WIAT, the West Yorkshire Association of Acute Trusts, and embedded anything that we did with the Scan4Safety program with the Leeds improvement method that Julian Hartley mentioned earlier today. And recognizing that the Scan4Safety program is an improvement program. It's a quality improvement in whichever metric of quality you want to choose, and it has to be embraced by the people who deliver that change. And without it, it will just remain a corporate function. I think that just to talk about the use cases outside of the inventory management, we've heard quite a lot about that, and the crucial MDOR reporting that's a key element for now and for the future. The bits for me, though, for what we're working on, live bed state, and I'll come back to that in a second when it comes to from a sort of regional perspective from emergency care, using admission, discharge and transfer functions of live scanning on ward areas and in clinical areas to really understand what our capacity is to take more patients into our bed base, and embedding that with some potential real-time location tracking that we discussed at our forum earlier today. There are some other sort of almost quick wins that we can utilize global standards for, and we've embedded the use of electronic observations, so scanning the patient's wristband and entering the blood pressure, etc., directly into the patient's record, reduces that sort of potential for getting patients mixed up with, as normally when our clinical teams do those observations, they'll do a number of them and then upload them, and it reduces that potential for human error. Blood tracking, so we're now able to sort of look at our really high stakes samples across our organization, from the lab to the fridges that are allow us to have immediacy of the availability of blood products. Indeed, in our mortuary, to ensure that when we do release a patient's remains to funeral directors, we absolutely know that we're doing the right thing. We've got excellent tracking for that ability to really understand, again, the consequence of getting it wrong and making sure we get it right. Looking into the pharmacy, we've heard quite a lot about closed-loop medicine and how global standards can allow the effective functioning of our medicines departments. It's still in the discovery and an understanding phase at the moment in Leeds, but that's where we're going to be focusing on for the next year or so. And I've already mentioned real-time location tracking, where we're utilising RFID type technology to follow samples and potentially patients in our clinical areas. The last little bit I want to mention with the urgent emergency care hat on is that the real problem for us in that pathway is ED crowding. It's about potential harms for patients who are suffering the long ambulance handover waits and the long wait for ambulances in the community, and utilising the improving flow in our hospitals, utilising real-time location tracking and the live bed state, understanding what we're doing on our wards reduces our length of stay, highlighting when patients are delayed because of for investigations, so it adds to their length of stay, and really understanding that granular data, utilising the global standards, is a way to augment all of the other stuff we're doing with our clinical teams to reduce length of stay. So that's really where we are in Leeds.
Thank you. It just goes to show the breadth of adoption of GS1 standards and Scan4Safety across multiple patient pathways as well. Thank you. Lee, over to you and your view on safer, smarter, connected healthcare.
I'd forgotten that Lee's got a load of money to do this. Every time he says that, I feel aggrieved. My journey with Scan4Safety in this, I'm an accountant by trade, a CFO, and I have a fascination with information. And this goes back sort of 10 years. I walked into a factory in Darlington that makes machines, really big engines, and it was pristine. And I was like, how do they keep it as clean as this? And then I went to a Jaguar factory in Birmingham. And what's really fascinating when you go in the private sector and you go into some of these places is they've got processes that are absolutely world class and really tidy and really efficient. And then I walked into the orthopedic stock room in Sheffield Children's Hospital. and it was really interesting. I was talking, so we had quite a big limb lengthening service. And the surgeons, literally, when you were kids, you used to have Lego. Well, they had Meccano. But some of these screws were from the ironmongers. And some of these screws were from reputable medical suppliers. They were all in a tray together. You couldn't tell which one was which. So when we talk about traceability, I'm sitting there thinking to myself, what I see in the private sector and what I see in the NHS is just way apart. Scan4Safety for me was a way in which I could start to use technology to codify information. And there was a further thing. I wanted to be able to engage my clinical body better. We had consultants in at one point who said, do you see the variation between individual consultants in a particular specialty? And if you could just narrow that variation. One of the most difficult things I have always had in my career is convincing clinicians to change their practice and to convince them that the data I was looking at was of some use and was sort of robust. It's a lot easier when you're comparing them with their colleagues next door rather than a hospital 50 miles away. And Scan4Safety gave us a way in which we could start to engage clinicians about their practice and again try to moderate their practices. What's really fascinating, listening a moment or two ago, was how much we're trying to do in Leeds, and yet when I look across the NHS, the variability is still huge. You've got organisations that haven't even started doing this, and some organisations that are really pushing the envelope. And I just think there's a real big levelling up for the NHS, and organisations have got to catch up. So for me, the safety argument was never in doubt. The ability to trace products and the safety and the time and the efficiency that brings, I don't think is arguable. The economic case has never been maybe as compelling, but for me, there's a reason why the private sector spend a fortune in getting all of this data, and they can't all be wrong. So for me, that's why I'm really interested in progressing this agenda. Thank you.
Thank you, Lee. And just going back on your point around using that data to look at reducing clinical variation.
Absolutely.
Nata, your view on the future?
So I think for us is connecting the hospital building to the patient safety and care. They are not disjointed. We are not building a school or a prison or a hotel because if in a hotel the air conditioning system doesn't work, you just get a grumpy customer who says, I was too hot or too cold. In a hospital, that can have a direct impact on the patient safety. If your air changes are not correct, you'll have a direct impact in your infection rates and the knock-on effect. So I think is one, making the construction industry understand that building a hospital is very different to building any other industry, but also connecting the data from the building to the patient care is quite important. And if you're going to have not have disjointed databases, because that's when you cannot use the data to understand the trail of or audits, we need to have a standard underneath of those foundations. So if a tab has a part number of 236 and the patient number is 236, I cannot manage it in my system because they will be clashing. I think one of the things GS1 provides is that global unique identifier where I can use a single system to understand that these patients' infections, these sets of patient infections has gone up, and I can trace them back. They were all done in this GLN, and that GLN relates to that air handling system in that theater, and I can fix that so the future patients will not be impacted. That's extremely powerful. And I think for us to utilize that and have the ability for, as I said, once in a generation where we are building new hospitals, where we can embed this from not as an afterthought, not as a stick-on, because that's costly. In my previous trust, I tried to implement GLN. The quotation I was getting was quite expensive, and I was like, there's no way we can implement this. But if I can embed it now from build, it doesn't cost that much. So I can have the locations in place. If I can drive the construction industry to implement these unique identifiers where I can scan those components and have them in my state management system, then I can effectively manage the whole system as opposed to silo sections in the hospital. So I think it's just connecting one inside the hospital, all the system, your estate to your patient care, and then also externally from your providers to get the industry, drive the industry to adapt these standards so we can utilize this single source of truth from the manufacturing all the way to the use and replacement.
That's great, thank you. So question for all three of you, and we'll start with Lee, if that's okay. How do GS1 standards or Scan4Safety support system-wide digital maturity and data sharing?
It's a tricky one, isn't it? I think for me, I think Nata used an analogy about the GS1 standards being the thread that sewed it all together. When I just referred to the Jaguar example that I saw, these processes are really slick, but when you start picking at them, right, underpinning them and making what they all hang on is data that says, I need a piece of equipment right now, and it appears. And that will then go to a stock room somewhere off-site. And so I think that the standards themselves are really important in providing that, I think you said the glue in that enables you to plan your processes in your business and make the whole thing, the whole operation more efficient. And but you do need the output of that is far more mature data. So that plays to your data maturity piece.
Yeah, absolutely. Steve?
Yeah, thanks. It's interesting about what is a system from a healthcare perspective. I'm just thinking about sort of our own local system. You know, we have a Leeds Place where we have a number of organisations that work together to provide care for patients who cross organisational boundaries. But I've mentioned the provider collaborative, West Yorkshire Association of Acute Trusts, who were actually sharing a Scan4Safety programme. And of course, then there's an ICB and the region and. I mean, I think the key for this is having standards and having data that we can all share. We've heard yesterday about sort of not putting all our eggs in one basket, particularly from an EPR perspective, but having the ability to share the data. And it's not just superficial sharing each other's dashboards, but it's actually sharing the data itself, and then we can use it to ensure that our patients can cross organisational boundaries with minimal disruption and seamless transfer of responsibility. And that, for me, is the key. So it depends on the system, but the approach is the same.
Thank you. Nata?
I think, as you mentioned by the colleagues, the standards basically underpins interoperability. Without standards, you cannot have interoperable system. You can have integration, which is very fragmented, and every time you change part of the system, everything else has to change equally in order for the data flows. But standards would underpin that interoperability, and the GS1 is the standard adopted by NHS widely. Hence why we try to push it through the construction, because you're building hospitals, which then you can have that data flow seamlessly. So I think for me it's the fact that it's the foundation to interoperability, any standards, and unless we adapt it and implement it and utilize it, we're going to have fragmented system.
Yeah. Absolutely. So my next question before we move to questions from the audience is, Scan4Safety is not universally adopted in England yet. Everyone agrees it's an absolute no-brainer. There's a lot being done around inventory management systems with the the NHS Supply Chain Deployment Programme. But Scan4Safety principles impact multiple use cases, as you've described some of those, Steve. But how do we get a broad adoption of Scan4Safety and GS1 standards across England?
Should I respond to that first? Yeah, and interesting that at our discussion group before lunch, a lot of that conversation about leadership was focused on, because the original few sites that had the funding and the focus in 2016, it was relatively straightforward because there was an exec lead, there was a group of individuals who were working on the Scan4Safety program. As the success of the Scan4Safety program has progressed and other organizations have taken on the mantle, it doesn't have that sort of unique selling point. It doesn't have that sort of, we've got the funding, we've got the individuals, we're going to do it. It just becomes another thing for a really busy, focused exec team with multiple pressures to identify resource for it. And the conversation that we had today was really salient about developing the narrative that becomes sort of overwhelming to say we just have to do this. Not doing this is a problem, and recognizing that the program affects the quality perspective. So CMO, chief nurse. It affects the estates and facilities. So director of estates and facilities, and of course procurement, etc. And once those, it's about getting key individuals to really understand the benefits. Once you have sort of 3 or 4, we talked about our chief operating officer because we report out to her and her team. And then you've got about 4 execs all really understanding this. And then suddenly you get that buy-in. And that's sort of, I suppose, our output of our discussion about how to really get really busy people to understand and embrace the benefits.
Thank you. Nata, I'll go to you next.
I think we need to stop thinking of GS1 as just a tech or a asset management system. It's a strategy enabler. It enables us to provide safer care. It is, as you say, it's a no-brainer, but it's so much connected to the patient safety. And it needs to be a second nature. It has to be done as part of everyday life, not as an afterthought, as a good to have or a nicety. Is a foundation to safety. So I just, as you say, I'm bewildered why, and we've made a promise that we're going to push this forward in the healthcare industry and try to make them also see the importance of having these standards and connectivity in data to enable the patient safety. I think at the end of the day, we're all here for the patients and their safety, and that just, nobody can argue against that.
Absolutely. And Lee?
I think Stephen's right in that if you can get advocates at board level, whether it's the chief nurse, chief medical officer from a safety perspective, that's great. I think the finance directors should be looking at this as being an essential part of the business. Cash is a really big issue at the moment in the NHS. You've got stock rooms, so you don't particularly want to focus on the inventory management piece. I get that, but there are finance directors up and down the country who are sitting there going, I've got some cash issues, and yet they'll be carrying weeks and weeks worth of stock, which is not desperately helpful. And I think more fundamentally, and this goes to Nata's point, it comes down to the power of information. The point I was making in my opening remarks was around why does the private sector, why do some of the biggest and most successful organisations in the world invest in this sort of stuff? And it's because they are driven for success, and primarily that's shareholder value and economic success. But the information that these systems provide is crucial to the success of their businesses. It's the lifeblood of their businesses. So I think that we cannot ignore it in the long term, and the NHS has to get on board with information.
Thank you, Lee. So I'm just going to, we've got about 5 minutes left. I'm just going to open the questions up to the audience. So I think if we can't see much, that's great. Any questions? We have one from Tim here at the front.
So I'm Tim Hurr, I'm the Chief Medical Officer at Frimley Health, and we're part of the new hospital programme. And we have lovely conversations with some of the team. And part of it is that there are two principles. One is that there has to be transformation of pathways. And there's also this thing about there's a certain core commonality of design going forward. I'm not one for compelling organisations to do stuff because people should come to that natural conclusion. But has there only been talk about actually, as part of the design strategy, putting GS1 structures in? Because this is about transformation. So the National Hospital Programme isn't shy of telling or advising us of what they would like. So I was just wondering whether those conversations have been had.
Yes, we are having, well, as part of the new hospital program, there is funding available for digitization because these future hospitals are digital smart buildings. So there are a core of intelligent hospital capabilities called, and one of them is asset tracking, which means in order to achieve asset tracking, you have to put a foundation in place, which is what one would hope is GS1. So the answer kind of, from that point of view, is kind of yes. From whether we can, and the GLN is again another part of ensuring that the global location numbers are inputted from the construction from day one. And then there's the Building Safety Act, which kind of mandates the traceability and the golden thread of information. And again, GS1 very much feeds into that whole Building Safety Act regulation. So it's a multifaceted approach for sure, whether it's implementing standards and ensuring that things are done from the base. Yes, I hope that answered your question.
Well, I was being slightly more transactional about how much you could compel people in the new hospital programme to think about GS1. And again, I don't believe in telling people. No. But I do think just whether that conversation needs to be slightly more overt.
I think once it's part of the reference design, that will be automatically adapted by the trusts who are building the Hospital 2.0. So we are hoping to be embedded into the Hospital 2.0 standard design.
How would you describe a Scan4Safety hospital?
As in the nirvana. So, you know, I suppose it's the purpose and the principles of what we're trying to do. As Nana said yesterday, we're trying to make the right thing the easy thing. So all of our staff are interfacing with our patients in a way that adds value to that patient and doesn't take the staff away doing stuff that doesn't add value. We acquire the data once automatically without manual input, and that data is used throughout the patient's experience. And we share the data that we can share with other organizations. We do not have to ask our patients to repeat clinical information unless there is a clinical reason to do so. I could go on for another 15 minutes, but we have 50 seconds left.
Lee?
I'm with Stephen on that. The nirvana for the hospital has got to be about patient experience. And it's got to be about the experience of the patients leading up to needing a hospital visit and what might happen in a hospital. But it's also got to be about giving the clinicians and the staff the tools and the information with which to do their job. If we can do that as seamlessly as possible, then that's got to be a good thing. If as a byproduct, I can get management information that helps me to run the hospital from a commercial perspective, great. But the first priority has got to be around the experience of both the staff and the patients.
Yeah, agree. Nata?
I think for me, nirvana is when you walk into a hospital, you cannot tell whether you walked into a private or a public hospital. Mm-hmm. And there is no reason for it to be that way, as you said. And I think data underpins most of that, because once you have the data, you can improve your flow, you can improve your pathway, and it needs to be a data you can trust. And unless you have the standards applied to those data, you probably won't be able to trust it as much. So that's my nirvana.
That's for... So the future of Scan4Safety, safer, smarter, connected healthcare is all about data, the use of that data and transforming patient pathways, multiple use cases, Scan4Safety principles embedded across the board. Brilliant. Thank you all so much to our panellists. Please can I have a round of applause.